Well, welcome. I'm Jim Hermiller from St. Vincent Hospital in Indianapolis, and we're here at CardioSource CRT 2014. We're really fortunate to have with us Dr. Corrado Tamburino from Italy, and we're going to talk about where the mitral clip is in Europe and around the world. In the United States, it was just approved for degenerative high-risk disease, and we want to get, I think, an idea from you. What's it like when you can really use it in the patients that need to be used, and give us some kind of impressions of how it's being utilized in Europe?
Yeah. First of all, I would like to start with my first mitral clip that was 6 years ago, so in 2008. So far we have an experience which is long-lasting, so we can have some established impression about the clip. So first of all, I would say that the clip should be implanted in all patients with mitral regurgitation and inoperable patient or patient that are deemed at high risk for surgery. This is the first point. So never implanting a clip in a patient who is suitable for surgery, at least at the moment.
Yeah.
We will see in the future, but so far this is the clear indication. The second point is that many of the patients we treated, at least at the beginning, and we are continuing on that way, is that our patients that stayed at hospital for a long time. They are under maximal drug assumption, and sometimes they are under intravenous drugs, and they stay in the ICU for a long time. So my impression is that after the clip is implanted, the patient do well, so they improve soon after. Mm-hmm. And in many cases we were able to discharge the patient that were staying with us for days or weeks after a few days, and this is an important point. Mm-hmm. So the main indication is a very end-stage patient with mitral regurgitation, mainly functional mitral regurgitation, and depressed ejection fraction, big volumes of the left ventricle, and in such cases, or patient with contraindication to surgical therapy, although less depressed ejection fraction. And in these cases, mitral clip is a very, very good therapeutic option.
Yeah. So in the Everest trial, we had some relatively rigorous exclusions anatomically. Yeah. Leaflet separation, LV volume, and ejection fraction that had to be above 20%. How does that play out in the real world now?
Yeah, you know that there are many studies, ongoing studies and registries. Olaf Franzen as well as Sinning, they published studies with patients with very, very depressed ejection fraction, below 25%, even 18 or 15, and diastolic volume by 250 ml, which is a big volume. So I would say end-stage cardiomyopathy with mitral regurgitation, or the study of Bioricchio in Switzerland, where we participate in this study in patients with non-CRT responder, so patients where also the resynchronization failed. And in these cases, the mitral clip provided good result as well as in other patients. So there was a dramatic improvement in NIA class, a reduction in mitral regurgitation, the sphericity index was reduced, and the NIA class has improved. So this therapy has proven being effective in also in terminal patients, in very high-risk patients.
Yeah. Comment a little bit for us about the procedural changes that have happened in the last 6 years since you did that first case. I know for mine 7 years ago, what we did then and now, 5-hour cases, now it's an hour long. Kind of just tell us about the technical improvements, the imaging improvements that have sort of facilitated the procedure.
Yeah. So what we did at the beginning was a careful evaluation of the patient that was selected according to surgeon, as all my patients. And was a patient with real depressed LV function and in really bad condition. But at the same time, at the beginning, we started implanting the clip also in elderly patient with degenerative mitral regurgitation. That could have been in that moment good candidates also for surgery, and we choose the clip because of age and some comorbidities. So in the years we excluded such patients. So if a patient is a good patient for surgery with a degenerative mitral regurgitation, we do prefer sending the patient to the surgeon because of, you know, that in the first 6 months after the clip is implanted in degenerative mitral regurgitation, we have a somewhat incidence of a recurrence of symptoms.
Yeah.
So we pay attention, we are very cautious on that. And then, what has changed in the 6th year? The skillness. So we do fast. So the time of the clip delivery time is almost in all cases below 15 minutes.
Yeah.
Because the skillness improves with the number you do. We did 180 cases, but in the last 2 years we did more than 60 cases per year. So we do 2 cases per week, something. And then we extended the indication. So in previously surgical patients, so patient with previous surgical approach, when the mini band fails, we are able implanting. We just published on JECC our report on 6 cases where we did successfully clip implantation in patients with previous surgery. And then we are asked from surgeons when there is some shocked patient with chordal rupture, and so they ask us to stabilize the patient with a clip, and then they treat the patient with a mitral valve replacement in case of need. And also in extreme cases when we, by definition, shouldn't be good candidates for clip, you can implant a clip. If you want to approach the leaflet, you start by paracommissural, implanting a clip, so you approach the leaflets and then you implant 1 or 2 more clips in the place you want to implant the clip, so reducing the mitral regurgitation.
Yeah.
So some tips and tricks that you learn doing the procedure.
Yeah, it's amazing how far this procedure has come. I can remember the early days, we had no idea what we were doing. We were just turning the knob and see what would happen, and now it's very systematic, and I think 3-dimensional TEE's been helpful too.
We use a lot 3D TE. During the procedure is not really useful. We did some live cases at PCR last year with a 3D demonstration. It is useful in some cases, and I think that the LVOT intracommissural views in 2D TE is mandatory, but the 3D echo is useful for assessing the proper anatomy of the valve before the procedure. And during the procedure is useful because it can be useful when you check from a surgical view the atrium, and you see the valve in front of you. In the upper part you see the anterior leaflet, in the lower part you see the posterior leaflet, and you can check the orientation of the clip. Is somewhat useful, especially I think for beginners, because you understand much better where you are, how to rotate and to orientate the clip.
So here in the United States, just starting up, where do you get most of the referrals from? The heart failure clinic, where do those referrals come?
So in my practice, I receive the patients from cardiologists. So I have many referrals in the whole country, and so many patients are referred to us because they are a heart failure patient with mitral regurgitation. So is from the territory, I would say. People working outside the hospital, sometimes also from the hospitals, from other hospitals, but mainly from cardiologists that work in the private surgery or in other centers far from our center. But we have many, many patients. The problem is that in my center, we started the structural program in 2007 with the first study, and there is a paradigm shift because we don't know how to behave with coronary patients, because we are full, plenty of structural patients that are long-staying patients,
Yeah.
especially TAVI patients. Before you have to do the TAVI, the CT scan, and then you have to prepare the patient, and then you follow the patient. It's very complex managing this patient.
Yeah, yeah. Well, as we get going in the U.S., what sort of recommendations, what advice do you give for new people starting out with the mitral?
My recommendation is at the beginning concentrated many patients in few centers.
Yeah.
Because learning curve and experience make more successful any procedure.
Yeah.
And this is a very demanding procedure because the learning curve is very steep. And before being really used to do routinely this procedure, and not in 4 hours, but in half an hour, it takes time. It takes time, and so this is what I recommend.
Yeah.
If you want to learn the procedure, you send your patient in an experience center, you go there, you learn there, and then you move in your center. But after months, after many cases performed in a single experience center. And then there are so many patients start doing the very, well-defined patient, where you are sure that you get a successful.
Some
successful,
coaptation, central jet, not getting out to the.
Then you move to eccentric jet, starting for paracommissural implantation of the clips. Is something that comes after, but at the beginning I recommend very straightforward patients.
Okay, well that's great. Well, it's been a great session. Thanks so much. We really appreciate it here at CardioTube and CR2014. Thanks so much.